Welcome to my personal analysis of the UWORLD question ID 2810. The patient is 66 years old male. Keep that in mind, we'll need that. The cause of visit is a routine follow-up. There is no complaint. Medical history is significant for poorly controlled diabetes, and this is really important along with the age. He's hypertensive. His current medications include glipizide. This is a sulfonylurea drug for his diabetes, which is poorly controlled. Furosemide and nifedipine, most probably for hypertension. They are changed, as we will see later. And aspirin, maybe for pain. Nothing is mentioned about the reason or the cause of this aspirin intake. And this is really weird. You should ask clinically. You should ask why is he taking it, or if you're routinely if he's visiting you routinely, then you would ask if the cause is removed or not. Like if it's a pain or something, you can just stop it. His vitals include high blood pressure. It's poorly controlled as well. 150/90, and the pulse is 78. So, since the blood pressure is poorly controlled, his diabetes also poorly controlled. Since this is the thing, if he's poorly controlled diabetes, then I need to focus on diabetes. This is regarding the clinical practice, not regarding the question. So you would at least do a random blood sugar to check whether or not he has abnormal glucose levels in his blood. So lisinopril was discontinued due to hyperkalemia. He was taking lisinopril for hypertension instead of furosemide and nifedipine, or maybe one of them, but it was stopped due to hyperkalemia. Why lisinopril? Lisinopril is the best for hypertensive diabetic patients. If you have hypertension alongside diabetes, then ACE inhibitors are the best option for you. It was discontinued because of hyperkalemia. Sometimes we discontinue it or change it to angiotensin receptor blockers due to cough, but in this case there was hyperkalemia, and ACE inhibitors are well known for their hyperkalemia for hyperkalemia. I'm sorry for this organization of the labs. The sodium is lower, the borderline lower, the potassium is increased, the chloride is increased, bicarb is decreased. This is where we start, and blood urea nitrogen is increased along creatinine. It's 1.4. It's not clear here. Anyways, if you divided the blood urea nitrogen over creatinine, it gives you 20, so it's not pre-renal. Pre-renal azotemia requires higher than that. This is the only option present here. But the thing is, there is increased urea nitrogen and creatinine. What is the cause? You need to check that. It didn't mention it. Maybe it's something related to the kidney stone or something. Maybe, perhaps. I have no clue. I honestly have no clue. And but it's not pre-renal since it's not above 20. This ratio between both of them is not above 20. This excludes that option. Where to start? You start by mentioning that or focusing on the fact that bicarbonate is decreased. Since it's decreased, you think about what? You think about acidosis, and you need to calculate the anion gap. How to do it quickly? You have the sodium level, you subtract chloride and bicarb, and this gives you 136 minus 108 minus 18. This gives you almost 26 or something. 28. No, it gives you 10. 28. That when you subtract sodium from chloride from sodium, like 136 minus 108, this gives you 28. You subtract bicarb, which is 18, it gives you 10. This is normal anion gap metabolic acidosis. You start thinking about two major things. There are a lot of things, but you start focusing on two: diarrhea and renal tubular acidosis. Okay, so you start thinking, oh, diarrhea, let's choose laxative. No, you don't choose laxative, because laxative, especially if it's abused, as mentioned in the option, causes hypokalemia, not hyperkalemia. Why? Because it's a state of dehydration. You use laxative, you lose a lot of fluid. This is dehydration. Then you start having aldosterone increase, and this is opposite to what you expect, because aldosterone increase would remove potassium and increase sodium, and this is the opposite. And the same applies for primary hyperaldosteronism and for renal artery stenosis. All three options increase aldosterone, so you exclude them. Furosemide use and cerebral vomitings cause alkalosis. not acidosis. That's why it's excluded. You are only left with renal tubular acidosis. Renal tubular acidosis, type 4. I'm speaking about type 4. Okay, I'm sorry I didn't add that. There are multiple types, but the hyperkalemic type is called RTA type 4. It causes non-iron gap metabolic acidosis. This is renal tubular acidosis, causes non-iron gap metabolic acidosis. It's hyperkalemic in one type and hypokalemic in other two types, but in this case it's hyperkalemic. How is it managed? It's managed by fludrocortisone, which is an aldosterone. What causes this disease? Okay, let's get back to the patient. All patients with poorly controlled diabetes, they have damaged juxtaglomerular apparatus. There is decreased hypoaldosteronism. There is hypoaldosteronism and hyporenin. So this is what causes this disease state. So what would you give? I would replace this decreased aldosterone by giving fludrocortisone. This is important to note because we care about the clinical practice. In this situation, in this case, you recognized renal tubular acidosis. What to do next? Okay, you have renal tubular acidosis. Congratulations. What would we tell the patient? You would tell him to take, or you'd give him fludrocortisone. You adjust the dose for him, or do something like that. The thing is, we start thinking about it in a clinical way or a clinical fashion. Think about the questions in a clinical way. What will happen if you encounter such case? You would give fludrocortisone. And that concludes my personal discussion on this question. If you have any question, any additions, do not hesitate to leave it in the comment section. Thank you and good luck.